Hello, I'm going to talk today about assessing the respiratory status of a child. The first thing that you want to consider when assessing a child's respiratory status is to ensure that the patient is in a position of comfort, whether it be on their parent's lap, whether it be sitting in a chair, laying in bed, sitting forward, laying down, whatever's comfortable for them. Before you even begin to touch the child, you should assess the rate and rhythm of their respirations. Are they breathing fast? Tachypnea. Are they breathing slow? Bradypnea. Are they taking deep breaths or are they taking shallow, short breaths? Are they grunting? These things are best assessed before touching the child. You may count the respirations without touching the child. As soon as you touch the child, the likelihood is that the child's going to cry. So the reason for not touching the child is because you want to keep them as happy as possible so you can get a good picture of what their respiratory rate and rhythm is. The next thing you will do as you proceed through your assessment of the respiratory status is to obtain a history from the caregiver. You will want to know the time of onset as well as the characteristic of the onset. Was it an acute onset or was it something that happened quite suddenly? You'll also want to discuss the characteristics of the onset. Was it precipitated by a fever? Have they had previous episodes of respiratory distress? Have they got a diagnosis of asthma? Have they had croup in the past? Are there other respiratory issues that the caregiver hasn't yet shared with you? Other things that you want to talk about when you're obtaining the history from the parent or caregiver is to discuss things that might not be red flags to them but would be red flags to you and I. Things such as consolability. Is the child able to be settled in the parent's arms in usual position of comfort? After observing the child's respiratory rate and rhythm, you will then observe the child for retractions. This illustration demonstrates suprasternal retractions, intercostal retractions, substernal retractions, and subcostal retractions. The depth and location of retractions is associated with the severity of respiratory distress in children. Intercostal retractions indicate mild respiratory distress, while supraclavicular, subcostal, and suprasternal retractions indicate moderate distress in children. When the child is using accessory muscles to help him or her breathe, that's a very good indication of severe respiratory distress in children. The next thing you want to observe the child for is the way in which they are sitting. Have they assumed a tripod position like this boy to maximize lung expansion, thereby making it easier for them to breathe? You want to then observe the child for signs of cyanosis. Here we see circumoral cyanosis, peripheral cyanosis, and finally we will see generalized cyanosis. Now that we have discussed observable features of the respiratory status in a child, we will move on to auscultating a child's chest. I want to make a note first of respiratory rate in children with regards to tachypnea, bradypnea, and apnea. Tachypnea is a good indicator of respiratory distress in children. However, bradypnea is a very late sign of respiratory distress and is very indicative of impending respiratory failure. Apnea is a prolonged period of time without effective respirations. Quite often in the emergency department, we will see children present in cases where the parents say the child did not breathe for a prolonged period of time. When a child does not take a breath for greater than 15 to 20 seconds, then there is definitely cause for concern. That said, children generally do have irregular respiratory patterns and may not breathe in a regular pattern like you or I, especially in the neonatal period. First, let's talk about wheezing. Wheezing is a whistling sound that can be auscultated in the child's lung in various places and is an indicator of narrowing in some part of the bronchial tree. Expiratory wheezing is a good indicator of this narrowing. However, inspiratory wheezing can be an indicator of severe narrowing in the bronchial tree. It can also be a good indicator when it is location specific to the presence of a foreign body in the respiratory tract. Wheezing is quite common in asthma. It can be also present in infectious diseases like pneumonia or epiglottitis. Now listen to a wheeze. And there you have what a wheeze sounds like. Stridor is another type of wheeze that is indicative of partial to near complete obstruction of the bronchial tree. It is quite often audible to the ear without the use of a stethoscope, very indicative of foreign body obstruction as well as croup. The presence of stridor in a normally healthy child is a good indicator of a medical emergency, and attention must be made to the matter in an emergent fashion. The child that presents with stridor is in acute distress and needs medical intervention immediately. Now let's hear what stridor sounds like. And there we have the high-pitched noise. Crackles, crepitations, and rails are the clicking, rattling, or crackling noises that can be auscultated in one or both lungs. They are often only heard with the stethoscope. In small children, infants and neonates, sometimes you will be able to audibly hear them. They are caused by the popping open of small airways and alveoli that are collapsed from fluid, exudate, or the lack of aeration during expiration. Crackles can be a good indicator of an infectious process, usually pneumonia in children, and a chest x-ray will be required to assess the nature of the crackling noises. And let's hear the noise of crackles. There we have crackles. When auscultating, be sure that you compare the left side to the right side. Are breath sounds decreased? Are they absent? Or are they unequal? This too can be a good indicator of the location of respiratory disease as well as the severity of the respiratory illness in the child. This concludes our respiratory assessment of the pediatric patient. This is a very general overview of the respiratory assessment. And as I always say, you need to listen to a healthy chest before you can understand what the sounds of an unhealthy chest sound like. So I always encourage my learners to always listen to a child's chest, even if their chief complaint is not respiratory in nature. This will allow you to gain a better understanding and hone your skills in respiratory assessment for pediatric patients. I hope you have enjoyed this presentation. Please follow up with the websites provided to practice your respiratory assessment skills.